A very good morning to everyone. Hope everyone is fresh and alert now. Uh, Pancreatitis is a very basic topic, especially for the exam going candidates, and definitely you will either have a theory question or you will have a case or case-based scenario, which is very important for you to understand how it goes. So we'll cover the topics in the following headings. We'll stick to the basics, not too much in terms of the trials, but how do we approach a case. As we all know, acute pancreatitis is an inflammatory condition of the pancreas, and most of them, around 70 to 80%, will have a mild course, but around 20 to 30% can have severe disease, and mortality can be up to 15% in such patients. And the presentation is usually inflammation. So inflammation, features of systemic inflammatory response, features of organ failures, including acute kidney injury, hypotension. This is how a patient presents to us. The most common presentation is pain, abdomen, nausea, vomiting, which is like an acute abdomen, which a person comes to the emergency and presents. And diagnosis, we generally do it with clinical features, laboratory or radiological. So generally, presence of the classical pain abdomen, either presence of biological evidence like raised amylase lipase or radiological evidence is at least two of the three should be met to say it is pancreatitis. So once we kind of moving towards pancreatitis, let us understand what are the etiologies. The most common etiology worldwide are gallstones and alcohol. So around 30 to 50% of the times it is gallstones. Alcohol is also significant, especially in our country, and other causes could be hypertriglyceridemia, sometimes post-ERCP. So post-ERCP pancreatitis, the incidence is pretty less. It is about less than 1%, but the severity is very high. So this is what we have to keep in mind. Trauma, blunt trauma to the abdomen, most often they can present with pancreatitis. Some rare causes such as drug-induced pancreatitis, all these things are known. But majority of the times, the most common causes are either gallstones or alcohol. So any patient who comes with pancreatitis presents with severe pain abdomen. So that's the classical symptom a patient comes with, which is generally acute, persistent, and is located in the epigastric or the left upper quadrant. So this is how they present with. Generally, you can see this is the position. The pain will be so severe that you tend to kind of have this symptomatic position. Nausea, vomiting is most often seen in around 90% of them. Patients who have much severe disease on presentation, who have significant systemic inflammatory response, or they can present who have other organs affected like ARDS, they can present with breathlessness and other features. So before we jump into pancreatitis, we always have to understand the timelines. The most important thing in a patient who present with pancreatitis is we have to understand it's not a 1 day, 2 day disease. It's a disease which runs in sessions. So the first week, the second week, and the subsequent time is the most important week, phase of pancreatitis. Generally, whenever we even counsel our families, we always say it can go up to 6 weeks. The initial phase is usually the first 1 to 2 weeks, and then followed by that second phase where we see local complications, and the third subsequent phase where we see complications because of certain local issues, for example, infected pseudocyst or other things. So understanding the timeline is extremely important. The first week, majority of them will present with systemic inflammatory response, significant end organ failures, hypotension. It all looks like a frank sepsis, but there is no sepsis there. We have to realize this, that it is all an inflammatory phase. And the second part is the severity. So it can be mild in majority, but it can be moderately severe or severe in other conditions. We'll understand the classification in the subsequent slides. And of course, the types and complications. So it can be a simple edematous interstitial pancreatitis, or it can be necrotizing pancreatitis. The most common used classification is the revised Atlanta classification. It categorizes its pancreatitis into two phases. One is interstitial edematous pancreatitis, which is a milder form, and the second one is, which we are all worried about, is necrotizing pancreatitis. So According to severity, can be mild, moderately severe, or severe. Patients who have mild disease will generally have symptoms and will not have any major organ failures. Moderately severe patients will have organ failures, but it will usually be transient, that will be up to 48 hours. And patients who have severe or persistent organ failures, which runs for more than 48 hours, will fall into the severe category. So, moderately severe and severe are the ones whom we have to watch for ICU care. So there are various other classifications. One of them is a determinant-based classification, but most often we use the Atlanta classification. As we've seen, mild don't present with any major organ failures. Moderately severe will have transient organ failure that's less than 48 hours, and severe will have persistent organ failure or worsening symptoms. So this is how we classify. So once we've understood pancreatitis, how they present, what is the severity, we also have to understand that where do we act, which patients will go into severe pancreatitis, which patients will end up with a mild disease. So there are a whole range of scoring systems that has been identified, like Ranson's, Glasgow, BSAP, Apache 2, Modified Marshall, but none of them are gold standard. BSAP is the one which is simple and easily applicable. So it is a bedside index which includes raised blood urea nitrogen, abnormal GCS less than 15. That means features of encephalopathy, evidence of systemic inflammatory response, age more than 60, or presence of pleural effusion. So these are the 5 points. Point more than 2 indicates increased mortality. Anything between 3 to 5 indicates the mortality of around 15%. So it's a simple bedside index which we can score the patient and identify the patient who will need more supportive care. So whenever a patient comes to the emergency, we are suspecting pancreatitis. The most important thing for us is to look for signs of severe pancreatitis. So any patient who is hypovolemic. So the most important thing which we will do is assess the fluid status, dynamic fluid assessment, and start him on fluid resuscitation. Identify any organ failures are there. It could be RDS, it could be acute kidney injury. And identify, of course, most of them will have systemic inflammatory response. So once we've evaluated for these 3 major things, the routine blood tests again includes amylase, lipase, and routine blood investigations. Immediate CT is not required. So the first thing which we have to understand is there is no need for a CT scan to be done on day 1. So unless we have a diagnostic dilemma, unless we are not sure that it is pancreatitis or it is a perforation or it is something else, unless we are having a diagnostic dilemma, there is no need for us to go ahead and do the CT, because the yield or the sensitivity is very less on first day or second day. So there is no need to do a routine CT. And laboratory evaluation, I think any patient who has a amylase lipase of more than 3 times, high CRP, hematocrit, raised urea, all these are markers of severe inflammation. So again, it helps us to identify the patients who are into moderately severe or severe category. So any patient who comes with severe systemic inflammatory response or comes with organ failures will need ICU admission. Any patient who falls into moderately severe category, that has persistent organ failure or severe SIRS for more than 48 hours, or markers like subtle markers like elevated hematocrit, raised bun, or having AKI, or aged more than 60 years, or are having severe comorbidities. These are the patients who we need to watch for, who may need ICU admission. So identifying who will need ICU is also very important. Imaging. So how many of you do CT on day 1? Anybody? So what else do you do on day 1? Any radiological investigation you would like to do? Yes. Right? So to understand the etiology, most often we do an ultrasound. Like everyone understands and believes, there is no need for a CT scan on day 1. After day 4, we generally do a CT, which is helpful because the sensitivity is close to 100% here to identify necrosis. The whole idea of doing the CT in a patient with pancreatitis is to again score them into what category they fit into. The most important thing which we want to identify is presence of necrosis. MRI or plain CT can be done in whom we are not able to give a contrast, sometimes contrast allergy and all that. Generally, acute kidney injury or on day of presentation or any time is not a contraindication for contrast. Many studies have shown that it doesn't change the outcome. So you should not be scared of doing a contrast CT just because there is AKI, but any other contraindications, for example, contrast allergy or pregnancy, we can use other investigations if it is needed. So now, once we have done the CT, when are we going to repeat it in frequent time intervals, or when do we have to repeat it, or we don't repeat it at all? So how to change this dilemma? Most often we have a baseline CT which we do on day 4. For if there is severe pancreatitis, sometimes some of the studies and guidelines recommend to repeat it after a week's time, but this is, it is generally not followed by everyone. The most important timeline where we repeat a CT is change in the clinical outcome. Most often in the second phase, after 15 days or after the second or third week, where we are expecting a patient to develop an infected pancreatic necrosis. Any patient who has a change in clinical features and showing features of infection or new onset fever and new onset organ failure. So this is the time where we want to evaluate where we stand in terms of the necrosis. So that time repeating a CT may be useful. So this is just the image. This is acute interstitial pancreatitis, where you can see there is a lot of fat strangling and edema. These are the later ones. You can see spots of necrosis here, and this patient has infected collections because you can see some air pockets on the CT. CT severity index, again, day 4, what we do is to understand how severe the pancreatitis is, and presence of necrosis, presence of extra pancreatic collection. So this is how the severity is assessed. So the most important management in the first 48 hours is fluid resuscitation, pain control and nutrition. So these are the 3 things which we always have to do and do it right. How many of you start antibiotics? Yeah. Right? So no role of empirical or prophylactic antibiotics in pancreatitis. So these are one of the grade 1A evidence. So definitely we should not start antibiotics unless we are thinking of some other diagnosis. So how much fluid to give, which fluid to give, how long to give. So earlier it was told to give a lot of fluids in pancreatitis, especially around, some of the guidelines used to quote around 300 to 500 ml per hour. But now the evidence is coming down. So we generally tend to do something called goal-directed fluid management, and it is coming towards a lesser or kind of restrictive strategies. So generally, dynamic fluid assessment, initially resuscitation with maybe around 10 ml per kg bolus, and then followed by a lower volume. So goal-directed fluid resuscitation is what is recommended nowadays, unlike earlier where it was massive fluid resuscitation. And also guide your resuscitation. So it should always be assessed with dynamic assessments and try to de-resuscitate appropriately. Generally after 2 to 3 days we tend to do that. Crystalloids are most often recommended. There is no evidence to suggest if it is to use RL versus normal saline. So the evidence is very low. So we can use any type of balanced crystalloids that is more useful, and definitely not to use colloids. Pain control is paramount. Most often the first point where pain control happens with fluid resuscitation itself, because intravascular fluid depletion can lead to decreased pancreatic circulation, sometimes ischemia, sometimes worsening necrosis, which can aggravate pain. So fluid resuscitation also plays a major important role in pain control. Opioids, patient-controlled analgesia, sometimes epidurals, all these things are tried. Again, no role of antibiotics. And ERCP, so any patients, I will again touch upon ERCP, but if there is no cholangitis, there is no role to do ERCP. So this is the latest change that we are seeing. Nutrition. So again, one more aspect which has a very good evidence is starting early enteral feeding. So in the first 24 hours, and there is no difference between nasogastric or nasojejunal. So we can either start with anyone. Most often nasogastric is enough. What we have understood is a delayed feeding was associated with a 2.5-fold higher risk of necrosis. So, and in need of intervention. So, chances of gut translocation, the chances of the necrosis become infected, all these things are being noted in few studies because of delayed enteral feeding. So one thing we should realize is any patient with pancreatitis feed early, unlike what was thought earlier to keep milk per oral for some time and all. So early enteral feeding is necessary. And minimally invasive strategy. So it has gone from a situation of keeping NPO, doing surgeries to stopping feeding, start early enteral feeding and doing minimally invasive or no surgery. So this is where the shift of change of management of pancreatitis has happened. Any patients who have infected pancreatic necrosis, we try to do interventions, and that also will be minimally invasive. It could be a percutaneous drainage or minimally invasive strategies using endoscopic necrosectomy. Generally avoid surgical interventions. That's the take-home message. And coming to complications, so we see a lot of local or local complications or systemic complications. Local complications can include pseudocyst formation, walled-off necrosis, or infected necrosis. So this is the pseudocyst you can see. This is infected necrosis of the pseudocyst, where you can see some specks of air. Yeah, this is the pancreatic necrosis. So again, for infected necrosis, minimally invasive strategies. Diagnostic dilemma is most often seen, and a minimally invasive CT-guided aspiration can sometimes be done. Carbapenems or antibiotics that penetrate the pancreas, most often quinolones and carbapenems are the ones. Quinolones is avoided because of the general resistance we see with tuberculosis. So carbapenems have shown to have good tissue penetration. Again, other strategies like ERCP has to be done only in the presence of cholangitis. Out of cholangitis, it is not recommended routinely. And percutaneous drainage, any patient who are present with infected necrosis, we generally tend to avoid any interventions before 4 weeks. After 4 weeks, it may become a little safer, and we act only when there is need for drainage, especially in the presence of infected necrosis. And other than that, absolute surgical indications could be abdominal compartment, fistulas, ischemia. So these are the conditions where absolute surgical intervention is needed. Otherwise, we tend to avoid it. And cholecystectomy generally is done in the index admission. So this is a new change which we are seeing in the treatment of pancreatitis. And any patient with mild pancreatitis, index admission itself, cholecystectomy is done. And of course, cessation for alcohol counseling also is important. To summarize, acute pancreatitis is a very important condition needing intensive care. We have to understand the timeline of disease and how the natural course goes for us to better manage the patient. Restrictive antibiotic use, goal-directed therapies and early enteral feeding have known to improve outcomes, and minimally invasive therapies are recommended whenever an intervention is needed. So, thank you.